about probably one of the most common, or I can say the absolute most common clinical diagnosis for children, and that is otitis media. We have great difficulty defining otitis media, so I will tell you what I think, and we'll go from there. We have and the reason that we have difficulty is because it's on a spectrum. So we have normal over here, and then we have this cycle of otitis media over here, and it just depends on where you get on the carousel as to what you call it. So we have some consensus about what acute otitis media is, and we have some consensus about what serous otitis media is, or otitis media with effusion, but the other terminology is confusing, redundant, useless. It's what people get promoted through academic departments on, so it's not really useful for us here. So, when we talk about like breast cancer, we like to talk about the tumor, the node, and the metastatic stage so that we can quantify who is going to do well and who is going to do poorly. There is absolutely no consensus about any of those things in otitis media, so we still don't really know, despite the fact that we have millions and millions of opportunities to have patients. We still just don't know who is going to do well and who is going to go down the path of being a child in my clinic and also adult in my clinic. So, okay, so otitis media. So we'll start with things that we can agree on, and we'll move to places that we just don't know. So otitis media with effusion, the effusion means that there is fluid underneath the eardrum in the middle ear space. So that effusion can be either serous or it can be mucoid, and sometimes, particularly this time of year, we will see mucoid effusions underneath the ear that are like spun honey. So anybody know what spun honey is? It's honey where you can grab it like this and go like this, and it's really thick and stringy and sticky, and those kids have really, really bad hearing. So otitis media, or acute otitis media, is the sudden onset of inflammation. That usually means that there is a purulent process going on underneath the eardrum, that purulent process is bacterial, and that there is bulging of the eardrum, there is limited mobility, and the eardrum is red and ugly. And little children or their parents who haven't slept for several days because of these symptoms may be irritable, not eating well, having vomiting, diarrhea, anorexia, and if the eardrum ruptures, they'll have drainage from the ear, and we call that otorrhea. That otorrhea can be bloody colored, and it can be impressive. There are certain characteristics of children that you may not know yet, like a 20-pound child can have 40 pounds of vomit or diarrhea in it. These things still haven't been explained, but until you've been thrown up on or pooped on, you're like, how is this all in there? The same thing can happen in the ear. The middle ear space is very, very small, but yet it can drain an amazing amount. So to diagnose acute otitis media, this is basically what you're going to have. If you have an adult, you can say, do you have hearing loss in that ear? So I cannot tell you how many Monday and Wednesday clinic visits we have from folks who have been to the urgent cares over the weekend because they've had an ear infection. So adult ear infections are very rare. Okay, so raise your hand. So we have 50 people in the room. So raise your hand if you've had an ear infection within the last 2 years. Really? Okay. Did you have hearing loss with it? Did you? Then you might actually have had it. So we have 2% of our population have had a real ear infection. So ear infections have fluid in the middle ear space. Fluid in the middle ear space causes what? Hearing loss. Right. So if the patient is like, my ear is killing me, and they don't have any hearing loss and their Weber doesn't go to one side or the other, then they probably don't have an acute ear infection. They probably have allergic rhinitis because cedar, juniper are through the roof. I drove through Texas a couple of weeks ago, and there was so much pollen in the cedar trees that they were red, because yellow and green makes, yeah, I was like, those trees are red. Wow. So those of us with allergic rhinitis are really going to suffer. So allergic rhinitis can cause negative pressure behind your eardrum because it doesn't allow your eustachian tube to open and close the way that it is supposed to. And if it doesn't equalize, like who's ever been on an airplane flight and had really severe pain in their ears because they have had a little bit of a cold? Yeah. So what that means is that your eustachian tube is not working, and you naturally would develop negative pressure because you have a high metabolic rate from the mucosa that's sucking up all the oxygen in the ear space, in the middle ear space, sucking your eardrum towards the middle of your head. This is where I live most of my life. Most of my life is spent explaining eustachian tube dysfunction, negative pressure, and the sequela from that, which is where we start right here with otitis media. So if there is no hearing loss with the ear infection, then it's probably not an ear infection, it's probably just negative pressure in the ear. So fluid is absolutely necessary for an acute otitis media. So how do we diagnose fluid in the ear? You can read the screen. So pneumatic otoscopy, and this is why this is so critical. Because if the eardrum moves, then there's not fluid in the ear. Now, I will also say that sometimes it can be very difficult to obtain cooperation from a child, and it can be difficult to see if there is movement in the eardrum. The new Academy of Otolaryngology otitis media guidelines have a strong recommendation for pneumatic otoscopy and for tympanometry. So a tympanogram is it's an expensive machine. Some pediatrician offices will have it, but it basically is where we put a probe in the ear canal, and we put a tone burst in the ear, and then put pressure that cycles through negative pressure and positive pressure, and we develop across the spectrum a compliance wave. And so the normal pressure behind an eardrum is 0. So if there's fluid, then it will not move, and we call that type B. If there's negative pressure, it will be centered over the negative area, and these negative pressures can be really impressive. They can be 200 or 300 negative decapascals. They measure it in decapascals because it's really small pressure. And then the normal tympanogram is called type A. So, and I remember things simply, so just remember, it's B flat. So B flat, C is negative, A is normal, because A looks like an A, right? A looks like an A. So tympanogram or pneumatic otoscopy to diagnose fluid. No fluid, no antibiotics. So up to 50% of the upper respiratory syndrome will be viral. So what helps a virus? All the things your mother told you. Yeah. So, okay, so otorrhea is discharge from the ear. Where can the fluid come from? So the fluid from the ear could be an otitis externa. So you can have lots of fluid that drains from an otitis externa. Could be from a middle ear infection. Could be from a mastoid infection. So the space behind your ear is called mastoid. Mastoiditis, so if you're in the emergency room and you have somebody who comes in, they get a head bonk, and everybody gets a CT scan from head to toe now. So you'll see folks who have had lots and lots of ear infections, they have symptoms consistent, or they'll have radiographic evidence of mastoiditis. Okay, so we're hamstrung by nameology that any fluid in the mastoid is mastoiditis. But clinical mastoiditis is a really ugly picture, and I'll describe that here in a little bit. So the fluid can come from the mastoid space. And then who was talking, somebody said about don't stick this thing in my ear because you could go to the brain. All right. All right. So simply driven, let's think about these spaces. So I have my ear canals, right? These are holes in my skull, and they go in, and then there's a roof over the middle ear space. But what's in the attic? The brain is in the attic. So the tegmen, right? So the tegmen is the bone that covers the mastoid and the middle ear space. And in certain instances, you can have erosion of that bone so that you get brain hanging down in the mastoid, in the ear. You can get cerebral spinal fluid in your ear. And so you can have the ability to poke the brain through the ear. It's a rare thing, but it does exist. If it exists, it usually is in an overweight female, 40 to 50. Don't ask me why. We don't know. But usually female, and usually one-sided. So if you have fluid on one side that is painless with hearing loss, think maybe it could be brain. Do you have a question?
It's kind of random, but okay, so I worked in a trauma unit where we had a lot of head injuries.
Yep.
And I've seen a few times like brain coming out the ears.
Yep.
Is that through
Yep.
that way you just described? Okay.
Yep. Because the top of the external auditory canal is also part of that tegmen.
Okay.
So you can have cerebral spinal fluid leaks that come through the ear canal. It's rare, but it happens. So trauma and temporal bone fractures. So this bone that we're talking about is the temporal bone. So this temporal bone, which is at adult size at birth, which is really cool. So that enables us to do cochlear implants on really tiny babies. Because it doesn't grow, it doesn't have to grow. So this temporal bone supports your brain and the fluid around your brain, and if you smack it and crack it, then that fluid can drain out. It's rare, but if you're going to go get a job at the University and be around trauma units, then yeah, it's more common. I have a whole lecture on temporal bone fractures if we want to go through that too. Okay, so perforation of the eardrum. So acute otitis media is a positive pressure event. It hurts a lot. So that's why these babies are really, really unhappy. So you'll see bulging eardrums under pressure with lots of fluid behind them. If you were to take a needle or a knife and poke the eardrum, or be right there when the eardrum ruptured, that fluid behind the eardrum would gush out. And then the patient will feel much, much better. So the acute perforations with acute otitis media, that's okay. You just give the antibiotics. You can give some drops, some otic drops. We would usually use Floxin, ofloxacin, in the Cipro family, or something called Ciprodex, which has ciprofloxacin in it and dexamethasone. Okay, so if you rupture your eardrum with an acute otitis media and you get a hole in your eardrum, if it doesn't heal by a couple of weeks, it's not going to heal. And if it doesn't heal within a couple of months, then you get to go through that process that we may have an example of to take a picture of tomorrow. So perforations must be surgically corrected through a process called tympanoplasty. And the way that we usually do tympanoplasty is exactly what was sort of described a little while ago. He was young. It's okay. But the way that we do tympanoplasty is we make an incision that goes behind the ear that basically follows the curve of the ear. We take fascia, so the muscle covering, we thin the fascia with a press to metal plates. We screw them together. Dry that fascia out so that it looks like a little potato chip. Take the hole that is in the eardrum, remove the healed edge, because your eardrum has 3 layers. The outer layer is skin, the inner layer is the fibrous layer, the middle layer is the fibrous layer, and then the inner layer is a mucosal layer. So when we get a persistent perforation, we have a sealing of the skin layer to the mucosal layer, and we remove that ring, lift up the hole, put fascia underneath the hole, pack the hole back down on top of the fascia, pack both sides with fascia, and that's a tympanoplasty. So, all perforations of the ear, negative pressure behind the ear, acute ear infections, serous otitis media are caused by the fact that the eustachian tube is not opening and decompressing the negative pressure in the ear that develops just because the mucosa and the lining of the middle ear space and the mastoid space have a metabolic rate that suck up the oxygen in the ear, and it creates negative pressure. So the root cause of all of those things is the eustachian tube. The eustachian tube opens in the back of the nose at the torus tuberi at the level of the palate. So if you have a nasopharyngoscope and you can put the nasopharyngoscope straight through the lower part of the nose and look right below the inferior turbinate, you're going to be staring right at the opening of the eustachian tube. So anything that affects the nose can also affect the ear, because your ear begins at the tip of your nose. So all of us who suffer from allergic rhinitis and whatnot can suffer fluctuation in the ability to clear our ears because we have allergies. So we spend a lot of time prescribing nasal steroids and antihistamines and sinus rinse. Oprah endorsed it, so we know it's good. To wash away the stuff that's on the inside of the nose that could be affecting the opening of the eustachian tube. Other things that cause eustachian tube dysfunction are that the muscles that open the eustachian tube insert on the palate. So any child with a cranial syndrome will have the potential for chronic eustachian tube dysfunction. Those cranial syndromes can be like Apert's syndrome, where we have craniosynostosis and really funny shaped heads. The most common thing that we see are Down syndrome and just cleft palate. So cleft palate kids almost universally will, even before they've had their first ear infection, will get a set of tubes at their lip closure or at their initial palate surgery in order to prevent the sequela of the upcoming almost 100% ear infections. So I mentioned this thing that I had said was radiographic mastoiditis. Let's go through the prospect of acute mastoiditis. So you have in your head certain spaces. So we have spaces in our maxillary bones, the maxilla called the maxillary sinuses. We have spaces between our eyes called the ethmoids. Adults, maybe 12 and up, will have frontal sinuses, and then we have a sinus right in the smack dab in the middle of our head called the sphenoid sinus. We also have sinus-like spaces behind our eardrum called the middle ear space, and then we have spaces in our mastoid called the mastoid space. All of those areas can fill up with fluid and become infected, and if you have a mastoiditis, then on the CT scan you will see the erosion of bone. So the symptoms of a mastoiditis are, number one, that you are as sick as a dog. So the patient looks really, really ill. None of you have acute mastoiditis. Now, if you were laying prostrate on the floor and you had a fever to 102 or 104 and you had a white count in the 20s with pain and tenderness behind your ear, and your ear was sticking out, then you are a better candidate for mastoiditis. The coalescent mastoiditis just means that we've gotten a CT scan and that we now have documented that you have melted away the bone behind your ear. Okay, so now we're moving from the ethereal world to pictures, and I think that this is probably where we should spend most of our time so that you can actually look at somebody and you can know something. So this is where we're going to go through and we're going to begin to define those things that we talked about on the examination. So this is taken with just a camera and an otoscope. So, all right, so here's the umbo. The umbo is the, and let me just tell you that if you're taking notes on this slide or whatever, this is very abnormal. So, so just write, you're not supposed to see all the stuff that I'm about to show you. But I put this here because all of the anatomy is intact. The eardrum is just under severe negative pressure. Okay, so here's the umbo. This is the end of the malleus. here is the short process of the malleus. The bone of the external auditory canal should be intact across this space, but it has been melted away by the chronic negative pressure. And we can see more of the first hearing bone than we are supposed to. So in a normal situation, we would see only the tip of the short process and the long process of the malleus, which ends at the umbo, and we would not see the neck and the head of the malleus like we see up here. The next hearing bone in the chain is the incus. The incus has an ice cream cone-like appearance, and it goes, the cone part goes off this way. The ice cream of the ice cream cone is the head of the malleus. So ball and socket joint, head of the malleus, incus comes and snuggles up to the head of the malleus. So we should not see the body of the incus, and we should not see the long process of the incus, which comes down like this. And one of these structures is a reflection, and the other structure is the stapedial tendon. So your stapes bone has a muscle tendon that connects to the stapedius muscle, which is present in the stapedial reflex, which protects your ear from really loud noises. So an 80 to 90 decibel noise will cause a contraction of that muscle, which will stiffen the chain to prevent the high sound pressure from affecting the inner ear. So here is this. One of these is the stapes, and the other one might be the crura of the stapes, because the stapes is the stirrup, and so we might see the backside of the arch of the stapes, and the stapedial tendon is coming off like this. This structure right here is the facial nerve. So the facial nerve is making its entry into the middle ear space at this point over here, transferring across the middle ear space to a point back here where it will begin to dive down towards the stylomastoid foramen. So you can see that an infection in this space over the transtympanic course of the facial nerve, and if I told you that the bone over that facial nerve is not like rock solid table, but like Swiss cheese. So that bone can have little perforations in it, and then if you put an infection on top of it, put it under some pressure, that infection can get through those holes in the bone, and you can cause swelling of the facial nerve, and you can get a facial nerve paralysis with an acute otitis media. So, if we think that a child has a facial nerve paralysis with an otitis media, that's a child that I would take to the operating room that day, that night, as soon as I could, in order to make an incision in the eardrum, a big incision, and put in a big tube so that I can get steroids, so I can get the infection out, and I can get steroids in underneath the eardrum to try to bring the facial nerve back. Usually the facial nerve comes back without any trouble. Okay, this is our much talked about, much written about, but completely useless cone of light. And why do I say it's useless? Because it's present, and this ear is terrible. This ear is, I mean, there's so much wrong with this ear, it's not even funny. And why do I say that there's so much wrong with this ear? Because this is an intact eardrum, and the eardrum has been suctioned under negative pressure over all of these structures. And this is a cholesteatoma just waiting to develop. So this is what we call atelectasis of the tympanic membrane. So it's under really severe negative pressure, you should not see anything except, in a normal ear, the only thing that you're going to see is the short process of the malleus and the young bone. Okay? So that's the only thing that you're supposed to see. Everything else on this slide is just here to show you the anatomy of an atelectatic ear. The two operations, the two big operations that I did today before I came over here were addressing this exact problem. What and why is this a big problem, you might say, is because the blood supply on the incus is on top of the incus. If I take the eardrum and put it under negative pressure and wrap it around the incus, I kill the blood supply and then kill the bone, and then I get an ossicular discontinuity, and that can cause a 30 to 50 decibel hearing loss in that ear. So today we spent a lot of time lifting up eardrums, putting little slices of cartilage underneath them, and putting prostheses underneath those things with tubes in place so that maybe they can hear. Okay, so retraction pocket is all of these spaces that are under negative pressure that are supported by this anatomy that is not supposed to be touching the eardrum. So you have the first herringbone, the second herringbone, eardrum sinking down in between those things. Those are retraction pockets. Those retraction pockets can be very dangerous because the outer layer of the retraction pocket is skin. So if we pull skin that is supposed to be flat into a pocket, the outer layer of that skin can become trapped, and that trapped skin will continue, it doesn't know it's trapped. It will continue to grow, and it will continue to grow, and it could form a cholesteatoma. So cholesteatoma is skin trapped in the wrong place. It is an accumulation of the stratified squamous epithelium in the ear. So if you think of a toilet paper tube, take the toilet paper tube, put an eardrum over the end of it. If you take that eardrum, pull it around the corner and into places where it's going to get trapped, like the mascoid, that is a cholesteatoma. There are things that are called congenital cholesteatomas, meaning that that comes with your original equipment. The menagerie that makes the middle ear, external ear junction is quite fascinating, and you can trap some of the external auditory canal skin underneath the eardrum, and at about the age of 3 to 5, we'll see a skin pearl in the anterior space that is pretty consistent with a congenital cholesteatoma. I think I have a picture of that either today or tomorrow. Acquired cholesteatoma just means that you have negative pressure underneath your eardrum, sucked your eardrum into the middle ear space, and you got this by just getting lots and lots of ear infections. So we might have a volunteer for tympanosclerosis. So this is the result of lots of ear infections. So right ear or left ear? Anybody? This is a right ear. So we'll hopefully we'll figure this out. So in the right ear, the malleus is anterior. So this is anterior here, this is superior up here, inferior, and posterior is back here. So let's go back to this ear. So this is a left ear. So this is the short process. And so you can see just the different angulations of the malleus between the right ear and the left ear. So That was a right ear. This is a left ear. So what's this right here? Umbo. Very good. So here's the umbo, and what's this up here? Short process. So this ear is more normal. So we see that bone is all the way across the top of the external ear in this position. We do not see the neck of the malleus. We do not see the incus, which should be back here. And this section right here is called tympanosclerosis. So tympanosclerosis is essentially calcium and phosphorus, which has been deposited underneath the skin of the eardrum on top of the fibrous layer, and it is solid rock. So in the operating room, I can drag an instrument across this, and you can hear it. It sounds like sandpaper. This can cause hearing loss itself. The tympanosclerosis can involve the hearing bones, and it can be very difficult to deal with. The bad thing about this is that since it is essentially rock in the eardrum, it has no blood supply. So if you get a perforation that goes right up to the edge of the rock, then you have to remove the tympanosclerosis in order to deal with that as well. Okay, so risk factors for otitis media. Daycare, smoking, pacifier use, not being being bottle fed, not using breast milk, cleft palate difficulty, family history. The reason family history is involved is that the angulation of your eustachian tube is determined by the position of your midface. You kind of look like your parents, so the midface position is going to be determined by your mom and your dad. If your dad had eustachian tube dysfunction, then you have a larger chance of having it as well. It could be mom, but dads get the rap for this. Your ancestry has an implication in this. This is very difficult to tease out, but Native Americans have a very clear predisposition for otitis media. That could be environmental. It could also be an immunopredisposition, and it could also be socioeconomic. So otitis media tends to affect lower socioeconomic classes because lower socioeconomic classes cannot make it to the doctor to get antibiotics. Not that antibiotics are going to stop all ear infections, period. If I had my way, almost no children would get antibiotics, but we'll talk about that too in a second. Okay, we know that otitis media has been around a long time. Egyptian mummies have shown destruction of the mastoid. Why in the world would I put up a slide from 1932 and tell you that 27% of pediatric admissions to Bellevue Hospital were due to otitis media?
Has it changed, like, the percentage?
Oh, we admit almost 0 people to the hospital now. But why?
Technology to see it back in 1932.
We were technology, we had some limitations in technology, yeah. Yeah. But what's the difference between 1932 and 2016?
A lot of antibiotics.
A lot of antibiotics. How many antibiotics did we have in 1932? Very few. Very, very few. And because we really hadn't been through, anybody a Shutterbug? Anybody have cameras? Anybody love cameras? No? Okay. This will be lost on you. Because we hadn't been through World War II, we hadn't had Zeiss and Leica make the best bomb scopes, and they needed something to do with their bomb scopes that they made for the Germans, so they made microscopes and cameras. So the introduction of the surgical microscope hadn't happened yet. So the idea that we should be poking these things and suctioning out the milliliter fluid hadn't quite happened yet. So, so this tells you that antibiotics and treatment are a pretty good thing. It's also, this gently says down here, Hippocrates, but Hippocrates said that acute pain in the ear with continued high fever is to be dreaded, for the patient may become delirious and die. So those things still happen. So why should we give antibiotics to a child with otitis media? Because there is an infinitesimal risk. It's a small risk, but it's not zero. There's a small risk of meningitis, brain abscess, and death. So if somebody says, why should we treat this child with, with this acute otitis media? Well, I think that there's a small risk of meningitis, brain abscess, and death. Those things still happen. I get a call about once a quarter. Yesterday was one of those calls about the patient who had brain in their ear and were concerned about an infection for their ear. So in the pre-antibiotic era, 1 in 40 people died of a complication from otitis media. So almost nobody dies. The reason I went into otology is that people don't die. It's the truth. So office visits for otitis media are going up and up. That could be, there's lots of reasons why that could be happening. The best studies for otitis media are done by this guy named Teal in Boston. You'll have, 1 to 4 episodes in the first couple of years of life if you're a normal individual. The data is astounding. There are 20+ million episodes of otitis media, 25 million office visits to the pediatrician and family practice doctor's offices for acute otitis media. Half of the children are given antibiotics, so that's 50 million doses of antibiotics. These are old data, so there's much more antibiotics given now. Peak age of otitis media is between 6 and 18 months. If you don't have ear infections by the age of 3, you probably skated through. If you've had your normal number of episodes of otitis media, then if you don't outgrow them by the ages of 5 to 6, then there's an increasing chance that you might end up in my clinic. The younger the age of the first episode, the more likely you are going to have more episodes. If you have 2 episodes in the first year, then you're really likely to, number 1, get pressure equalization tubes in your ear and get lots of sickness. Number of family members, socioeconomic index increases your risk of ear infections. Daycare is an increased risk for ear infections because children are just bug factories and they will share everything. Pacifier use is not good because it creates negative pressure in the nasal pharynx, and you can suction fluid from the ear. You can get, if you have negative pressure in your ear, then you suction fluid down out of the ear and then up, and you can eventually get bacteria that go up the eustachian tube. Sleeping prone is not good. Seasonal difficulties, so we have acute otitis media more in the winter, lowest in the summer. Breastfeeding is good. Those are the contents of milk. Okay, so acute antibiotic use. If you live in England, or I'm sorry, if you live in Europe and you're under their managed care, hardly anybody gets acute mastoiditis. So the only way you get an acute mastoiditis is that you get an acute ear infection and it gets really bad, and then you get an acute mastoiditis. So this slide shows that this is incidence of mastoiditis per 100,000. So Netherlands, Norway, Denmark, they give almost no antibiotics, and they have 4 episodes of mastoiditis per 100,000. United States gives almost everybody an antibiotic, and we have decreased that 4 to 2. Good job. Good job. The long and short here is that we probably give too many antibiotics to our children, and that we could probably give a lot less and not suffer any of the dreaded complications of mastoiditis, meningitis, and brain abscess. This is just a cartoon to show that there are important structures that are around the middle ear. So here's the eardrum that is opened up for us. You have a vein that drains all of the blood out of your brain called the jugular bulb, or the jugular vein. It is in the inner ear. The internal carotid artery makes an appearance in the inner ear. The eustachian tube. You have another muscle in addition to the stapedial muscle, which attaches to the first hearing bone that is supposed to protect from sound. You have the facial nerve, and then you have the inner ear. All of those things can be affected by an acute otitis media that has gone awry. Okay, so in the next 10 or 15 minutes, we'll run through these slides, which I think are probably the best use of these presentations, because it gives you things that hopefully you may see later. Okay, so this is a right ear, and this is a hole in the anterior part of the eardrum. This is likely a hole that came from a tube in the ear. Okay, so this is a right ear again. So here's the short process. Here's the long process of the malleus. Here's the umbo down here. Some scattered tympanosclerosis around the eardrum. And then this is the big hole in the inferior aspect of the tympanic membrane. This stuff down here is what the hypotympanic bone looks like. The bone of the middle ear is kind of like an egg carton upside down. You'll have lots of hills and valleys in the ear. So this bone right here is not further holes, but it's just the bone in the ear, and it's the way it looks. So this is a marginal perforation, so just think of a bicycle tire. If you have spokes left that are distal towards the ear canal, then that's a central tympanic membrane perforation. If the perforation goes all the way to the rim and the tire, then we call it marginal. Marginal tympanic membrane perforations are at a higher risk to form a cholesteatoma. Cholesteatoma, again, is skin that's trapped in the wrong place. Why is that? Because remember from our time in the external ear, the eardrum and the skin over the eardrum migrates. So you have this migration of epithelium that comes out from the umbo, and it has to go somewhere, and so it can go down and around the corner of the perforation and go underneath the eardrum and create an acquired cholesteatoma. This is a really ugly tympanic membrane perforation. So here's the short process of the malleus up here, the long process of the malleus in this direction. Here's the umbo. Somebody want to give a guess as to what this large white structure is up here, anterior? This is our friend tympanosclerosis. So this is an ear that has been pushed and pulled. So it has been through many cycles of positive pressure ear infection, negative pressure, positive pressure, negative pressure, weakening the eardrum, causing the layers, the 3 layers of the eardrum to slide across one another. So those layers slide across. Your eardrum doesn't like to be slid across, and that causes a large amount of inflammation. That inflammation will cause the deposition of the calcium and the phosphorus. And this is a large plaque of cholesteatoma, or not cholesteatoma, tympanosclerosis. And then we have a big hole in the eardrum. Underneath the area of the umbo is a named structure in the middle ear called the promontory. Promontory means hill. The promontory is the opening for, or the presence of the cochlea. So this is the basal end of the cochlea. And then this is the round window here. So your cochlea, your inner ear, is a a hydraulic structure. So you have one window that is pushed on by the stapes. So you have to have a pressure relief valve, and so if you push on the stapes, that pressure has to go somewhere, and it comes out the round window. And so this is the round window. These things are, I like to say that, these things are only things that Netter can see, so they are in your Netter book. I assume we still use Netter? Do we still use Netter? Yeah, I don't know if anybody else would use it. So here's a retraction pocket and an effusion. So here's the short process of the malleus. See that we can see more of the neck of the malleus than we really should be able to see. Long process of the malleus, umbo. This arrow is here because this eardrum is sitting down on top of the incus. And then there's fluid here as well. So short process of the malleus, long process of the malleus. Notice how this looks really short. This looks much shorter than in the other pictures. That's because the malleus, which you are supposed to be able to see full on, has been retracted away from you, and it's what we call foreshortened. And then this large suction down negative pressure eardrum area is right down on top of the promontory. And you can't see the edge of this, so it's around the corner of the ear canal. This is how we develop skin trapped in the wrong place. So another ear picture. This is the right ear. This is the short process of the malleus. This is the umbo. This is an eardrum which has been sitting here for a long time. The incus has been melted away. The long process of the incus has been melted away. And the eardrum is sitting down on top of the stapes. And then another very curious anatomic finding is that the taste nerve to the anterior 2/3 of the tongue runs underneath your eardrum. So Very, very common to have an ear surgery and say, well, I feel like I have, I'm sucking on a metal coin or something, metallic taste in my mouth. Reason for that is because we either cut the chorda tympani is the taste nerve, or we have stretched it. I try not to do that, but sometimes it's in the way. This is another really ugly ear. So short process of the malleus, long process of the malleus, surrounded by tympanosclerosis. Incus is melted away. Here's the tip of the stapes. Deep retraction pocket around the corner. This is an ear under severe negative pressure. All right, so this is the picture of our friend, the congenital cholesteatoma. So this is a right ear. Here's the short process of the malleus, long process of the malleus, umbo, and in the anterior superior quadrant is a white mass. And so it looks like a pearl. Looks like a pearl underneath the eardrum. The original description of cholesteatoma was the beautiful tumor because it's really pearly and quite iridescent. So a pearl underneath the eardrum in the anterior inferior or the anterior superior quadrant in a child is highly suspicious for a congenital cholesteatoma. Another really ugly eardrum. Here's the short process of the malleus. The bone at the top of the ear canal has been completely melted away. We can see the head of the malleus, the junction between the head of the malleus and the body of the incus. That's what the number 1 is, the body of the incus. We get almost no appreciation of the length of the malleus, and then the umbo is very far away from us, so this is an ear under really negative pressure. This area in the region of the short process of the malleus, the neck of the malleus towards the head of the malleus, is a place that we call the attic. And so if you were to look in with an ear that has fluid behind it and what looks like a wax accumulation in the top portion of the ear, this would be consistent with an attic cholesteatoma. Just another really ugly ear. There are no landmarks in this ear, and the eardrum is pulled down around the corner of the posterior aspect of the external auditory canal, and so you really can't see any normal anatomy here. The normal anatomy gets melted away by the pressure of the eardrum. If you're concerned about a cholesteatoma, the symptoms of a cholesteatoma are foul, painless drainage. So any patient that says, yeah, I get drainage from my ear every now and then, they give me antibiotics and it goes away. That is the clinical story of a cholesteatoma, foul, painless drainage. When you look in the ear, you'll see granulation tissue and the body trying to deal with the fact that there's skin trapped around the corner of the external ear. Okay, why is cholesteatoma a big deal? Remember that we were talking about the spaces and the things that live up above the ear. So this is your brain. This is the external auditory canal. This is what's left of the malleus. This is skin trapped around the corner in the attic, and this rim enhancing area here is the edge of the cholesteatoma that has melted away the tegmen. So you are supposed to have bone that goes all the way across. That bone would look just like this, or it would look just like this outer edge. You're supposed to have bone that goes all the way across, that goes over to this area, right where the pin line is, that's supposed to be bone.